our session today, we have the honor of inviting Dr. Magdalena Romanowitz and Dr. Horatio Ochman, also known as Dr. H. Dr. Romanowitz is an associate professor of psychiatry at Mayo Clinic in Rochester, Minnesota. She has recently been appointed as co-chair of research in the Department of Psychiatry and Psychology at Mayo. For the past 7 years, she has managed the busy young child clinic for children aged 0 to 7 years. She also developed a young child track in the Child and Adolescent Psychiatry Fellowship, allowing fellows to receive training and certification in therapies such as parent-child interaction therapy, also known as PCIT. Additionally, Dr. Romanowitz serves as the co-chair of the Infant Committee at ACAP. Dr. H is a clinical professor of psychiatry and human behavior at the Alpert Medical School at Brown University. He is an attending in child and adolescent psychiatry at Rhode Island Hospital, Hasbro Children's Hospital, Bradley Hospital of Lifespan System in Providence, Rhode Island, and he is a faculty at the Boston Psychoanalytic Society and Institute. So we are thrilled to have Dr. Romanowitz and Dr. H with us today. Thank you, and the floor is all yours, Dr. Romanowitz.
Awesome, thank you so much. I'm gonna share my slides. Can you see them okay? All right. Grace, thank you so much for this lovely introduction and invitation, and I'm really honored to do this today. And I have a big task ahead of me tonight to cover the topic of psychotherapy research in about 30 minutes or less. So the question that I would like to pose today is, how do we conduct a psychotherapy research? And I hope to show you today that it's not obvious, it's not easy, but it's very, very exciting. So as Grace mentioned, I'm associate professor at Mayo. And this is a picture of me and my daughter, who's 7 years old. And actually, this picture was taken in front of Mayo Clinic. I have nothing to disclose. And I'll tell you a little bit about my career trajectory. We'll talk a little bit about reasons why studying psychotherapy presents with difficulties. And I hope to tell you a little bit about different research models in psychotherapy. So first, my path to child psychiatry, as you can tell by my accent. I'm not from here. I was born in Poland, in a very, very small town in the south of Poland. This is my family. My mom, my dad was taking the picture, my aunts, my grandparents. And as you can tell, if you want to look fancy in Poland, you need to wear a white shirt. And it's still true today. This is me and my 2 brothers. When it was time to go to high school, I decided that I wanted to go to a really good quality high school, which meant that I had to essentially leave home at the age of 14. And as you can see by this next star here, I decided to go to Warsaw, which was about 4 hours by train. So obviously not realistic to travel every day. So I went to this boarding school that was run by nuns. It was a Catholic school, and it was in this gorgeous, gorgeous building that was kind of historically preserved. For example, this wall still has to this day holes, bullet holes from World War II. So it was kind of an interesting experience growing up surrounded by history. As you were entering the school, there was a Latin sign that said ora and labora, which means pray and work. And that's pretty much all I did in high school. And then in Poland, when you finish high school, you go straight to university. We don't have college. And so from early on, I knew I wanted to study medicine. My father is a physician, still hard at work. And so I decided to go to Warsaw Medical School. And we also have a lot of opportunities kind of within Europe to do exchange programs. And so I was lucky to be able to go to Budapest in Hungary. And that was very, very lucky because Semmelweis University is just like the most gorgeous medical school in Europe. And that's where I learned about this thing, USMLE exam, and you can do your residency in United States. And I remember I look at the USMLE books, and they were so wonderful and practical. And I thought, my goodness, studying in doing residency in United States must be just the best thing ever. And I decided to do my residency in US, and I was again super lucky, and I was able to do my residency at Mayo Clinic. As you can see, Mayo is just gorgeous, always growing, developing, and so it was a fantastic time, and that's I had a fantastic time during my residency, and that's where I got inspired to be a child psychiatrist. And I decided to do my child psychiatry fellowship at Stanford University, which also was like another dream place to be. So I was really, really lucky in my training. So that's kind of my path to child psychiatry. And I'll spend just a few minutes telling you a little bit about my interest in psychotherapy. So I've also always been very fortunate to have the best mentors and supervisors. But as you know, in psychiatric residency in US, in the first 2 years, you pretty much just do inpatient care, emergency room. And so I was kind of getting a little bit frustrated because I was seeing pretty much the same patients kind of circulating from inpatient. Hospital stays already back then were pretty short. And so, patients were getting stabilized very quickly and then discharged, and pretty much, very quickly after they would end up finding themselves in emergency room again. And recently I heard this just gorgeous talk by neurosurgeon who would find similar frustrations in his specialty. And he likened those to leaky roof, where, you have a house with a leaky roof, and you fix the walls really well, you paint them beautiful, and you fix the floors really well, but you never address the core of the issues. You never fix the leaky roof, right? So the next time it rains, the walls are destroyed again, and the floors are destroyed again. And so you're back to square one. You have to fix the floors and the walls again. And that's kind of how I felt it was for me in those first 2 years. And then it gotten better in my third year when I was able to do some psychotherapy, where I felt like maybe I was attempting to patch those roofs a little bit with the use of psychotherapy. But I quickly realized, my goodness, I was so unqualified in my skills and I needed to improve. And so I started reading very extensively about psychotherapy. And initially, I read very general books, Mate, van der Kolk. And then I moved to more technical books. And I wasn't picky. I loved structure therapies like CBT and PCAT, but then also very much enjoyed more dynamic therapies like CPP. And then in my fellowship, I became interested in psychoanalytic training. And since I'm European, I was very much drawn to Lacanian school of analysis. But then I quickly realized that I would not be able to do it in my clinical practice. So I never completed my analytic training. And so as I was doing it, therapies clinically, I started asking questions about how and why they work. And I was curious why some patients responded best to structured therapies while others needed some dynamic approaches. And that led me to interest in research. And so I started reading Eric Kandel, who I'm sure you all know, Nobel Prize winner, psychiatrist. And he kind of gave us a little bit of blueprint of how to go about it, how to study a psychotherapy. And this is 1979 quote where, he says, when I speak to someone and he or she listens to me, well, there is an action that happens on the level of the neuronal machinery in the brain. And hopefully that also has a long-lasting effect on that neuronal machinery in that person's brain. And so, well, we need to study that. And we did. We did study it diligently. And as you see in this beautiful quote by Kasdan, decades later in 2009, he says, after decades of psychotherapy research and thousands of studies, still we have no evidence-based explanation of how or even why the most well-studied interventions like CBT produce change, that is the mechanisms through which they operate. So then I was kind of back to square one. Why is it so hard to study psychotherapy? So this is me a little bit showing off. I studied Lacan. And in his mind, it's so hard to study because as human beings, yes, we're biological beings. We have the brain and the body, but we also have language. He was very interested in language, and language is a little bit, difficult to study and difficult to capture. But the point that I'm trying to make is that there are levels of reductionism that are helpful. For example, we are still using biopsychosocial formulation in psychiatry. I'm sure you're familiar with that and you're using it every day. And it's very helpful to describe what is going on with a patient that is in front of us. And I do think that this integrative approach in research, where we bring different elements from different levels, from the molecular to the brain-based to the psychosocial, and showing this kind of dynamic interdependence between all those different elements is very, very crucial and a way forward. And we do have some studies now that attempt to do that, and they do it well. So let me tell you a little bit kind of how to approach studies in psychotherapy. And I want to start with a study of a single case because it's a really easy way to start research, start your kind of research practice. And there have been studies of a single case that really move the practice in a very profound way. And we actually still use them in, I'm sure you guys are familiar, you use them in your training. The Piggle, the study of Gabrielle by Winnicott, Ghost in the Nursery. The picture that I use is not a psychiatry picture. This is a picture of actually a Polish cardiothoracic surgeon who just finished first heart transplant in Poland. But this is just for me to make a point that everywhere in medicine, we very much still use a study of a single case. Unfortunately, I feel like we've been using less of those in psychiatry, and I think it's a shame because those are very helpful and very important. I personally have used studies of a single case in my career, and those have been tremendously helpful to me I was able to publish one of those in Orange Journal, and I'm super, super grateful. This was a case of a child who lost both parents to suicide. It was a very difficult case for me. Working with the editor was incredibly helpful. And then after the case was published, I received some feedback from the community. And then I was able to present it at ACAP, which also was incredibly helpful and supportive to me. So I highly encourage you to do that. Another way of doing kind of scientific discovery is case series. And here I show you a very well-known case series. This is actually one of the most cited paper in Orange Journal, which is mind-blowing. It's case series published by Lenore Terre. I'm not sure if you're familiar with the 20 children who survived the 1976 Chowchilla kidnapping. This case series really moved the field in ways how we understand young child remembrance of trauma and the impact of trauma on children. And so tremendous impact on our field. And you could say, well, this is only case series, but it had a huge impact on our field. So again, kind of example from my field, this was a very small feasibility study. We only had we had tiny budget of $3,000, but we had a good idea, and so we were able to recruit only 10 patients. This kind of came out of frustration of mine. I was sitting in my office after hours, and a wonderful colleague of mine, Dr. Atreya, who's our AI engineer, knocked on my door and asked me what I was doing after hours. And I told him that the Young Child Clinic is overwhelmed with patients, and parent-child interaction therapy has a very long waiting list. And I wish I could do something about it. And he said that, well, maybe AI technology and wearable technology could do something about it. And we decided that we could potentially, with the wearable technology, create decision trees to predict child's behaviors. But we wanted to make sure that what we were seeing on wearables, so little watches that the children were wearing, were comparable to sort of, what we were seeing in the real world. And so we decided to kind of prove concept on inpatient units. And so we asked our nurses who were monitoring kids 24/7 on inpatient unit to kind of follow and write all the behaviors and behavioral log that we created. And that allow us to compare the behaviors that we were seeing on the watch with the behaviors that the nurses wrote down for us on the behavioral log. And then we were able to create decision trees that were trained to use heart rate and sleep data to predict calm, playful, or impending disruptive behaviors. And we were mostly going after disruptive behaviors. That's kind of what we wanted to predict. And only with 10 patients, 10 participants, and a teeny tiny budget, we were able to predict different behaviors with 80% accuracy. And then that allowed us, that little bit of data allowed us to put in for much larger grants. And I'll tell you in a second about this much larger project where we use this, what we learned from this study in the psychotherapy project. So before I do that, let me kind of circle back to this important question, this important CAP psychotherapy research agenda on mechanism of treatment and how the treatment works that I kept asking all along during my training and early career. And you might ask me back, Why bother? Why do we need to know that? Because as of a 2000 paper by Kasdan, we have 550 psychotherapies. Probably now we have even more. Most of them are not evidence-based psychotherapies. And the division between psychotherapies is not as simple and shouldn't be as simple as evidence-based and not evidence-based. But this is the division that we have currently. And the reason why it shouldn't be as simple is because, in particular, that pile of not evidence-based psychotherapies, in that pile, it's a little bit like a black box. The psychotherapies are not equal to each other, right? Some of the psychotherapies that are not evidence-based are potentially really helpful and really effective, but they are still waiting to collect data to be labeled as evidence-based. And some of those therapies potentially could be even harmful. But right now, they're all in that one same pile, and so equal. And so that is quite worrisome. And even the evidence-based therapies, they are all kind of also in the same pile, and we don't have a hierarchy of therapies. We don't know which one works how and with what patients the best. So if we knew how therapies work, then we would be able to put some kind of order to them and hierarchy. So that would be extremely helpful to us. But in order to do that, we need to study 3 ingredients, and those are what is needed to make treatment work, and those are mediators of the treatment. We need to know optimal condition that are needed for the therapy to work, and those are moderators. And we also need to know exactly what is needed, kind of the critical items that are needed, that we can't lose in the process of moving therapy from the lab to the clinic. Because the clinics are oftentimes charged with kind of sloppiness, and when the treatment is moved from the lab to the clinic, suddenly the treatment is not as effective. But remember, when we study the treatment in a lab, the researchers can pick and choose the patients that they want to study, and a lot of the criteria are carefully selected and set. The clinics don't have that luxury, right? They have to see all patients that come through their door. And so it's always going to be much more messy. And as a result of that, oftentimes much more difficult. So when we move from the efficacy to effectiveness, we need to know how to do that a little bit in a little bit more organized fashion. So I'll tell you a little bit about my recent study of psychotherapy that we called Pistachio, or Preemption of Disruptive Behavior in Children. And it was a parent-child interaction therapy study. I mostly see young children in my clinical practice, so we did it, of course, it was for young children. We used a very simple wearable device that you can buy at Best Buy, any store that's very inexpensive, because we wanted it to be accessible for everybody. And studies on wearables have not been done in young children before. So my daughter has always been kind of a test patient for me for a lot of things. And so she was our patient zero, and she had to wear it for a long time just to make sure that we can actually study it on patients and they will tolerate the watch. But as you can see here, she was very happy to wear the watch. So, and we did spend a lot of time kind of thinking about, how to design the study. first inclusion criteria. We actually wanted it to be as generalizable as possible, and reflect the reality of any young child clinic. So we decided to accept patients with numerous comorbidities, on and off medications. Children with autism were allowed to receive also ABA therapy concurrently because it's a standard of practice. So we were not picky and choosy with patients at all. And PCAD is also a well-known treatment, so we didn't want to compare it to waitlist because we wanted to start building that hierarchy of treatments. So we decided to compare it to a gold standard, which is a PCAT standard protocol. And we obtained numerous assessments, pre and post treatment, but also mid-treatment. And we obtained psychometric assessments, but also clinical diagnostic assessments for clinical significance of the treatment. And I think it's important to also obtain biometric, look for biometric measures of treatment. So that's why we used the watch partially. And so we obtain activity, respiration, intensity of activity, sleep. We didn't do the stress because it was proprietary. And we essentially developed this kind of digital health ecosystem to send messages to parents before the tantrum happened and send them messages what to do to manage the tantrum. I'm running out of time. So here are our aims. We wanted to evaluate feasibility. It hasn't been done before, effectiveness of the treatment, and then also we wanted to look into those biomarkers. So very briefly, results. We have a lot of results when you do the AI wearable study. You have like literally millions of data points, which is awesome and daunting at the same time. On the left-hand side, it doesn't seem exciting, but it was very exciting to us to be able to really, in very detailed way, measure adherence. And as you know, in a lot of psychotherapy trials, especially in child, adherence is poor, but we had a very good adherence, and we were able to measure it in like very, very detailed way. And then on the right-hand side, the teal color is treatment as usual, and then the orange-red is the AI arm. And we were able to decrease tantrums in a very significant way. Those two are very significantly different. And so that was very, very encouraging. So my peers, look for mentors. If interested in clinical research, make sure it aligns with your clinical work. It's important to look for how and why psychotherapy leads to change. Yes, it's very important to study biology and biological correlates, but we should also look for psychosocial mechanisms. And there are different funding sources that we can certainly talk about. I've had a lot of wonderful mentors. Thank you so much to all of them. And we'll take questions at the end. And I'll give floor to Dr. H.
Hi, everybody. I am gonna share my slides also. Let's see here. Can you see it? Yeah, you can? Okay, and you can hear me? Yes, okay. All right, so basically, Dr. Where are my slides here? Oh, sorry, hold on, I'm gonna do it again because it disappeared for some reason. Second. Okay. All right. So the Dr. Levy, invited me to this forum on research, and I told Dr. Levy, I'm not a researcher par excellence. I'm a clinical person. Why on earth you're inviting me to this research forum? And she said to me, well, we want you to talk about, your journey, your career, a little bit of, good vibes and things like that for the young doctors, the residents, the fellows, the young trainees, and probably a little bit of a connection between clinical work in psychotherapy and research. And then give you a little bit of my pearls of wisdom. But basically, I just wanted you to know a little bit about my life journey towards the passion of applying psychotherapy in child and adolescent psychiatry. And this was, oh my goodness, here. Okay, I got it. How I chose the mind, and basically how I chose the mind, and it had to do with my early childhood, the family dynamics within my family system, where I came from, and the culture had in Buenos Aires, Argentina, where I'm from. Basically, one of my main dilemmas was how to learn. So when I was 8, I wasn't able to learn at school, and basically my learning was arrested by anxiety. Whoops. So I think that one of the major problems that I had was actually having an overachieving family, and that was no joke. Everybody, I'm coming from a numerous amount of emotional intelligent people, and they are, all, we are immigrants from Russia, all Jewish. And everybody, my great-grandparents emigrated from Odessa, from Ukraine, and Russia after the Russian Civil War in 1917. So there were 2 colonies of immigration, one to the United States and the other one to South America. So Argentina was at that time in the 60s, Buenos Aires, a very, very cosmopolitan city and very diverse, full of European immigrants. And there were a lot of people in psychoanalysis coming from Europe. And the cultural background in Buenos Aires for middle, upper class people was that basically you don't go just to the gym to have actually physical exercise, but you go to analysis also to have to exercise your psyche, to exercise your thinking, to exercise the process and how you're going to grow, your mind. Basically, I was really having a little bit of trouble, learning. And I had great parents, by the way. They'll say, Horacio, B is fine, do not worry. Of course, they were so good, but the internal pressure to perform was really overreaching my little mind. So by that time, my grandfather and my father later, they started a company on electronics in Argentina. So I was actually groomed in business, and I was groomed in art by my dear mother. But nobody was a doctor. Everybody was in business and engineering and law. So my wife's parents took me to the doctor. So when I was 8 years old, my doctor actually was my first mentor. He was, he trained at the Child Guidance in Philadelphia in the United States, and then he came to be the chair of the Children's Hospital in Buenos Aires. And when I was 8 years old, I started play therapy. That was 1968. So a little bit of play therapy, and then I was, I landed on a couch 4 times a week from ages 9 to 13. And I realized that I was starting to learn again, and I was really hungry for knowledge. And then, at that age, right, you would say, how on earth play therapy and talking did this to me? It was really a discovery. So I was really very curious around the mind. I started to look into my psychoanalyst library. Of course, as you can see in the picture, he had all the psychoanalytic studies of the child. And I said, what on earth is that? So, while he was at break, I generally, or from time to time, I asked him permission to look at the books. And some other books, there were titles on neurology, on psychiatry, on Sigmund Freud, on Anna Freud. And then I started to ask for anatomy books to my parents to look at the brain, and still thinking about what is talking therapy doing to me. So I had lots of individual analysis, and then I think that it was time for me to discover what is an adolescent group therapy. So that was between ages 14 and 19. So I thought that that was really cool because it was a way to learn adolescent development. So for 3 hours weekly for the lapse of 5 years, I was with 12 different adolescents, boys and girls, with 12 different narratives and conflicts in the here and now situation, doing Gestalt and psychodynamics. And everybody's parents were around our minds, and in the through the atmosphere of the big office, that we were all with 2 therapists. And of course, sexuality, gender, anxiety, depression were actually the themes, the classic themes that they will never die. They go through 1 year to the other, through one generation to the other. So I had really great mentors and as analysts, and through that, my passion for medicine grew, and I knew already I would say in adolescence or even before 14, that I wanted to be a psychiatrist, a child psychiatrist. So I had great professors at the University of Buenos Aires that enriched us with a lot of knowledge. We didn't have all the resources that, fortunately, the United States have. Nothing was given in a tray, and we had to eat the books and textbooks because knowledge would tell you how to proceed. There was no abundance of tests to order, and you had to think hard, study hard, consult the professors, and learn from their experiences. So learning from the experience is something that it was in my mind since early childhood, even before I started to read, Winnicott in England, learning from others. And then I did a little bit of adult analysis, and I started a residency in psychiatry with professors of psychiatry and psychoanalysis, both combined in Buenos Aires, from, of course, the Argentinian Psychoanalytic Society. And I started to study Sigmund Freud probably at age 19, 20 in study groups with psychoanalysts from the Argentine Institute of Psychoanalysis. And after my residency, basically it was really good because at the end of my residency, I was able to be in the child psychiatry program with my child analyst. So we were able to see patients, and I was an adult already together. So he said, Horacio, it's time for you to explore the world. So he gave me some alternatives for that. I transitioned to London, England for a fellowship in adolescent psychiatry at the Tavistock Clinic, which was at that point in time really one of the most golden years of my life. I studied, in a psychoanalytic European Mecca where Melanie Klein worked. And I had a lot of intellectual mentors, not besides the usual suspects of MDs and psychologists and social workers. I had philosophers and writers and people that taught me how to think also a little bit outside the box and with, philosophical concepts and literature. I had my own analysis, my training analysis there with pros and cons of leaving my country of origin, but I needed to challenge myself and pursue my goals in my own terms without family intervention. My family was great, and I have all good things to say about my dear parents and my siblings and my family, but I needed to do my own journey. So I went to London, and for the first time there, I saw immigration currents of people from other countries, because when you're in Argentina, the majority of the people are white Caucasians. And here I started to see people from India, from Pakistan, from Asia, all over. And I said, "Oh my goodness, this is so exciting!" Having to work with a lot of diverse population. I wasn't used to that, and it was the first time my patients were telling me about their narratives and their original cultures. Also, I underwent training analysis there, and the formula for the analysis at the clinic was, it's hard to know your patient or listen to your patient if you do not listen or know yourself. So basically, I realized that having personal analysis was a very important thing to have in order to understand and listen to patients. So, and of course, it was always this question, is a diagnosis a priority, or is it the development of empathy a priority first? When I was very curious in England, with hunger of knowledge. So basically, my child psychoanalyst did really a good job. And I was writing sessions and eternal supervisions, with mentors. That was in the 80s. And I learned about the British School of Psychoanalysis and Winnicott and Melanie Klein and Freud. And I learned institutional dynamics and leadership in organizations. And of course, around the corner of the Tavistock, it was actually Sigmund Freud's house. When he emigrated from Vienna, he had to leave Vienna because of the Nazi regime. And I basically also sneaked into the Anna Freud Center to know a little bit about Anna Freud. That, Anna Freud and Melanie Klein, they were a little bit like two different kind of very opposite currents of schools of child analysis. And basically my temple, it wasn't Jewish, it was psychoanalytic. And I was actually in Freud's house at least 2 times a week, thinking, meditating, looking at his books and looking at his archaeological artifacts, going to talks. And it was really a very, very, very good, very good way to educate myself in a very rich knowledge environment. So when I finished my fellowship in adolescent psychoanalysis in England, Argentina was not ready for me to come back. And being a medical doctor was really difficult. In Argentina, you know, you have to go through very difficult exams. When you pass, you go to university and you study for free. But there were so many doctors that they were actually working as cab drivers over there as well. So I became a foreign medical graduate, and I had to study 6 years of medicine in one to take all the exams in the United States. And of course, I went through the visa nightmare because I wasn't an American citizen. So, basically, I said, all right, I passed all the exams, very tough years, but at the end of the day, it was an investment to my knowledge and to my career. So I landed in Chicago, where they had a really good, you know, psychoanalytic residency from the Chicago Institute of Psychoanalysis. And basically, they let me waive my my adult section. So I did adolescent psychiatry, and one of my first mentors was Dr. Naylor. And then I was very, very fortunate and to go to MGH and McLean Child Adolescent Psychiatry Fellowship. There was no matching program, and I was the only foreign doctor in the Department of Child Psychiatry, actually the Department of Psychiatry in general. And we're all Jewish, but you know, my curriculum was just empathy plus analysis plus you know, training in psychotherapy. That was it. I didn't have a lot of research. So I had great mentors there, like Dr. Berresin, Jelinek, Whelan, Spencer Biederman, and the Boston Psychoanalytic Supervisors. And after that, I landed finally at Brown Medical School, Hasbro Bradley Brown Hospital. And I was actually, my goal was to be a generalist, like a PCP, but of child psychiatry. So I decided to specialize in different branches of child psychiatry. So I wasn't an expertise in a specific thing. So I did community psychiatry, the trenches, I named that. I did hospital psychiatry to see kids with medical problems in the interface with psychiatric problems. I did school psychiatry. Still, I'm a consultant at behavioral therapeutic school. Global mental health, which I've done in Central America and probably now in Argentina with the poor. And I also did private practice altogether. So, and of course, my major pleasure was to teach medical students and general psychiatric residents, child fellows, and triple boarders. So basically, as of today, I teach the triple boarders, I supervise them, I go with them to their therapies with patients, I sit with them, I listen, I help them. It's not just supervision, you know, on patients coming, on the trainees coming to see me with their, and telling me about their patients, but actually live. This is the way I did it in England as well. So, of course, you know, all this was actually given with a touch of psychoanalytic psychodynamic therapy, mixed with neuroscience, mixed with psychopharmacology. And of course, being in America, I wanted to learn American psychoanalysis. So I did my child psychotherapy training at the Boston Psychoanalytic Institute. And when I finished the training, I became faculty there teaching. I'm still teaching child psychoanalysis to the Harvard System Fellows in child psychiatry, psychologists, and social workers. And last but not least, our fantastic family in ACAP, which I have been nearly 30 years. It was a great family to be part of, so you could actually network with your colleagues and be part of committees. So I was in the psychotherapy committee, in the global mental health committee. I'm currently at the lifelong learning committee, where I have to read papers on research in child psychiatry, and trying to connect them with clinical practice. And I've been also in social media as a non-member. And I mentored medical students, fellows, early career psychiatrists, presentations. I had an expertise in the interface between psychopharmacology, and psychodynamics. And we published, actually, Dr. Ritbo, who is with us today. She was the editor of the Child Psychiatric Clinics on Psychotherapy, and I had my chapter there. And currently, I'm mentoring a junior attending to implement psychoanalytic psychotherapy curriculums. Actually, not necessarily a curriculum, but the projects that they like. It's called the Sci-Fi program with Dr. Ritbo, Dr. Drell, and others. Basically, this is my second mentorship there. And it's so rewarding because you learn from the whole group. You give a hand to really young attendings to fulfill their dream of, either mostly teaching psychotherapy in their hospitals with their trainees. So anyways, I did a lot of yada yada with my career, but I just wanted also to tell you how to engage in research-focused psychotherapy. So my view really is, in order to really have the passion for research in psychotherapy, you have to learn all kinds of psychotherapies. Although, so basically I bought books, I went to workshops. Although I was, married with psychoanalysis and psychodynamics, and I learned the Latin American school, the British, the French, and the American school of psychoanalysis, I also learned others. So I learned CBT and DBT and PCIT and all the abbreviations that there are: group motivation interviewing, mentalizing, mindfulness, interpersonal psychotherapy. I did 3 years in Argentina on training on family systems. And once you know what you really like and you apply the psychotherapy that you like, then I would actually email the experts and ask if you can help them to do research with them, because that's the first way really to learn. My own research in psychotherapy was really reading so many cases, clinical cases, vignettes, generally many ways in which I saw many kind of things that I didn't understand in therapy. And then when I went to read the cases, I could understand them because actually I could correlate both the papers that I was reading with what I was seeing with my patients. And that's what I do with my trainees. And as Dr. Romanowitz said, we don't have a lot of evidence-based research nowadays. And basically, there's not a lot of major research, like in others, besides, in child adolescent psychiatry, besides the psychotherapy, where you have lots of patients to do research. It's really difficult to do research in psychotherapy, although Nowadays, there are manuals, even there's some research coming up in psychodynamic psychotherapies and other psychotherapies. So I think it's very, very important. And clinical work and research feed each other. So if you don't have really good clinical basis, it's going to be difficult to do research. And if you don't study research, it's very difficult to do clinical work as well. You need actually to be completely up to date in research. And that's why one of the reasons that I do a lot of reading with, at the Psychoanalytic Institute, and then I am in the Lifelong Learning Committee at the Academy, at ACAP, reading actually research on child psychiatry. So, am I doing well with time? Yeah, I think so. Okay. So once another thing that I think it was really interesting for me is that once you are settled as a young attending, one has to diversify, because that's a way that personally I took, to have internal wellness and not to be burned out, and to look outside the box and apply other things that you like as well. So as I was groomed in business, and we have a 110-year-old company in Argentina, we do all electronics, and in Latin America, I went to business school to understand how it worked. And then I applied it also to ways in which I could understand here in the US, CEOs, their behaviors, their dynamics, how they function within their startup companies. So I've been actually doing startup companies for the past 15 years. And as I grew up in a farm, I did also introduction to veterinary medicine. And I also shadowed the animal psychiatrists. And I learned a lot of animal behavior, up to a point that I was going to do a little bit of research on the strange situation between a dog and their owner. So that actually, we looked at the papers, and it was really, it was done by other vets, but the Ainsworth strange situation was translated also into animals and owners. And also I did global mental health. I traveled with a whole bunch of doctors with different specialties. And I was a child psychiatrist, and I organized the mental health for the poor children in the middle of agricultural lands in Honduras, and also going to be doing it in Argentina. And as my dear wife said, you have to, stop studying and doing degrees. I asked her permission, so I had to interrupt my veterinary training, and I asked her permission to study history of art, because I was groomed in art by my dear mother. So I actually just came back from Oxford, England, from the campus, and I'm in the middle of a degree on the Certificate of Higher Education in art history, and I'm applying that to medical education, where I'm actually doing at the Harvard Macy's School for Educators, how to interpret art and bring my trainees from Brown to the museums, and do some narrative therapies, and do some institutional dynamics, and try to understand how they think in terms of emotions on their work and their relationship with colleagues and other staff members where they work. So, oh, I forgot this one. So Dr. Romanowitz asked me to actually think a little bit about what's going on, why it's so difficult to follow clinical psychotherapy nowadays. And basically, after seeing so many fellows and triple boarders, you know, I wanted to tell you a little bit about the internal dialogues that they have. And it's a struggle, and it creates a lot of struggle. And if they don't really follow their passion, it creates burnout on them. So these are some of the internal dialogues that, you know, young docs have. I have to make my salary. Psychotherapy alone will not be financially or sustainable for me, and even more if I have a family. Oops, my employer is not offering it, and if he or she does, it's extra time for me. Is it worth it? Too bad. I thought I pursued child psychiatry because it was fun to learn my patients' life histories. Life with an F, sorry, there's a typo. Life histories and their cultures. It is really that I do not have the time for this, or is it that I feel that I was not fully trained on it during residency? Can I make at least a pilot time and learn from it and see if I really miss the art of psychotherapy? If I have no clinical experience in psychotherapy, how am I going to pursue research in the area? To build up a good clinical practice, also research is paramount. So they both feed each other. Clinical work and research in psychotherapy go hand by hand. They're like siblings in a family. I must be honest on what I need after all these years of training. Otherwise, I will regret it. And if I let it pass and do not think about it, I will have a lot of consequent burnout. And if I see so many kids for meds only, will this be fun for me? Oh my God, I fear I will be burned out fast and I will have to look for someone else. For something else. I need to think what I need for my sanity in this career as well, because it's a stressful career as well. Finally, I hope everybody is awake, but I cannot see the rest. I'm seeing the slides. Some pearls. I wrote a little bit more than 5, so I apologize for that. So if you're interested in psychotherapy research, you probably have to have a good clinical experience in psychotherapy. Know yourself before you take care of others. Personal analysis is key to implement psychotherapy on others. Learn from experience through ups and downs. Be consistent and curious. Mentorship is a must. Ask for help. Never worry alone. Achieve emotional intelligence. I had so many mentors, it's very difficult to name them. Basically, Dr. Ritbo comes to mind because she's with us today, and she was a beloved mentor for many years when I was in the psychotherapy committee, and she was awesome. Thank you, Rachel. Achieve emotional intelligence. Pay attention to your close relationship and family. If you don't have emotional intelligence, if you don't pay attention to your own affection, to the relationship with your family, to your friends, to your partners, then it's going to be very difficult to work on what you like. It's not just, putting, career number 1. For me, number 1 is health, then comes family, then comes friends. Then you tied up that together, and then it comes your passion for work and motivation. Be interested in what others do and think. Be diverse. Try to learn other things that you like besides medicine. Explore diverse communities, domestic and international. So I go to 4 congresses, 2 domestic, ACAP and the American Psychoanalytic, and 2 international, the YACAPAP, the Child Psychiatry International, and the International Psychoanalytic. So I really enjoy it because I'm able to know, colleagues from all over the world, and I get basically invited to talk, in their countries, which is really cool. Prioritize health, family, and friends. If you're happy with this balancing act, you will be able to be more creative and focused with your work. Try to have a balance between neuroscience, psychopharmacology, psychotherapy, and research. Educate, educate. It's our legacy to our young doctors' generations. Mentor others, pose a question. And finally, and this is the last slide, pose this question to yourself. Are you satisfied practicing child psychiatry from the neuroscience research perspective and psychopharmacology perspective? Are you having fun knowing your patient? If the answer is yes, great. If the answer is a no, or you're in doubt, you're missing the psychotherapy piece to be able to know your patient's stories and develop a passion to listen and understand their lives. So I wanted to thank you, everybody, this late to listen for having listened to me. And this is my email if you want to connect with me. And I really am very grateful for the invitation, and thank you to all.